Good morning. My name is Keynote Metayer. I'm a faculty at the University of California, Berkeley, and I'm a cancer epidemiologist working on childhood cancer for the last 20 years. I would like to thank the organizer for inviting me to do the opening keynote for this very interesting workshop on helping investigation of unusual pattern of cancers. I will be giving an overview to kind of set the stage of this workshop. So first of all, for those who are not as familiar with childhood cancer, this is a very heterogeneous group of cancers, and they have the particularity to have different age distribution. And as you can see on the left part of the graph, the young children up to age 5 tend to have leukemia or umbilical tumor or childhood brain tumors. And as the age progress, the type of cancer that we observe are more in line with what we see with adult cancer in terms of solid tumors and lymphomas. But the most striking observation over the past decades is that the incidence of cancer in children is increasing. And those data are taken straight from the SEER database that I investigated last week to show that the numbers of cancer in children is increasing. In the top bar, you see the rates for leukemia. In the blue bar, you see the rates for childhood brain tumor, then lymphoma, and rarer cancer of the bones. But all of them have this trend that incidence is increasing over time. What's also interesting to see is that not every child is equal. We see racial and ethnic disparity in the baseline risk of certain cancer, but also in the speed at which those cancers are increasing in incidence. So here we see childhood leukemia. Latino children have a higher background risk than other children, but they also experience the fastest increase in incidence, where children of white or Asian backgrounds or Black children tend to not see this pattern. But what we see for childhood leukemia is not necessarily what we see for other cancers. And that cartoon shows the trends for childhood brain tumor. And here, white children tend to have the highest background risk of brain tumor. And we see a slight increase in incidence as well. What's striking here is that Black children show also an increased risk in incidence. So you can see there is some different pattern, different group of children are being affected by different type of cancers. And just to let you know that this trend is not just seen for young children, less than 15 years of age, we also see a new trend for early onset cancers in adolescent and young adult. And this is an example for testicular cancer, but I could show samples for thyroid cancer, for colorectal cancers, where young adults and adolescents now are starting to pick up some of those cancers that were not seen before. And here we also see an interesting pattern where Latino men have more and more cancer being diagnosed at the population level, to the point that they're going to reach pretty soon the level that has seen historically in white men. So what does this tell us? Obviously, the environment at large, where we live at large, must influence those fairly recent trends, whether it's exposure to chemical, your lifestyle, your diet, your immune function and development, social and historical determinants. And what the racial ethnic differences are telling us are those differences or are those disparities? Is the environment impacting the risk of having those cancer by itself, or it's in combination with background genetics? But overall, the message is where you live matters. And this is the topic of our workshop today. And I will be pointing to interesting work that epidemiologists have done to try to answer this question. So, for example, residential proximity to pesticide use has been well investigated in many parts of continents, different continents in Europe, in Italy, for example, in France, here in California. Many investigators around the world have looked into the role of being close to pesticide use is increasing the risk of having a child develop leukemia. And we have been working in this ourselves here in California. We are obviously very concerned because this is a region of high production, of high use of pesticide, a region where the majority of the farmers are Latino, and the conditions working in the fields are pretty difficult and obviously have a high likelihood to expose you to those pesticides. What we've done too is we went to visit some of the homes of the participant of our study that was taking place in the Central Valley here that I show in California. And that was an opportunity to collect dust. Dust sample is a very interesting media because it has the possibility to tell you what are the persistent compounds that are in your home that has been there for years and years. And many of those we track from outside or we produce from, inside from our lifestyle and what we live around. And the interesting observation for this dust sampling was that samples taken in Latino households were more likely to contain many of those chemicals. And whatever is above this line 1 tells you that it was seen in a Latino household more often than it was seen in non-Latino household. And you can see that many pesticide, many polycyclic aromatic hydrocarbon coming from either outdoor pollution or indoor pollution, flame retardants were seen more likely in Latino households. And our observation in our small study is corroborated by what we know at this population level in California. This is a cartoon that shows the correlation between the percentage of the population that is Latino in a census tract against a marker and kind of an overall marker of exposure to different pollutants or a marker of a socio-demographic disadvantage. And this composite score tells you that some community are highly impacted from different angle. And here that shows that Latino community have a high burden of all those harmful environments. This is another example where spatial risk analysis has helped to point to specific exposure that has been found to be associated here to hepatic tumor in children. That study was taking place in Texas, and the investigators were correlating the spatial clustering with what is known in terms of possible exposure to chemical, and here the link was being made to hazardous air pollutants. Air pollution has been a major concern in terms of understanding its impact on the development of childhood cancer. The reason being is that many chemicals that are found in those mixtures of emitted by air pollution are known to trigger some pathways that can lead possibly to childhood cancer. Those pathways are known to lead to other conditions in children and during pregnancy, but they are well known also to possibly trigger childhood cancer. So with this understanding, many groups have investigated the role of air pollution and childhood leukemia. This is a graph that shows a pooled analysis that have combined data from different parts of the world to show that the closer to a traffic density, the higher the risk of developing leukemia. And researchers have used more refined matrices here using air monitoring to measure directly benzene, which is a known carcinogen in adults, to show that there is a dose response associated with risk of childhood acute myeloid leukemia. Air pollution has also been investigating in the context of other cancers. Here, again, this is a study from Texas that has looked at proximity, maternal proximity to major roads in the context of embryonal tumor. And the investigators looked at different types of embryonal tumors because those are heterogeneous. And also, reported an overall increased risk of developing those tumors should the mom be exposed to traffic density. Other groups, in terms of understanding where you live matters, have focused on proximity to gas station, which is more urban, in an urban context, and also have reported a twofold increased risk of childhood leukemia when the home was close to a gas station. And lastly, I will give this example of a more emerging concern of living in proximity to fracking wells, which are unconventional oil and gas development, which has the potential to emit different type of chemicals and radiological compounds in the air and the water. And a study was published a few months ago to show that proximity to this to the fracking had the potential to increase the risk of childhood leukemia, whether you were the parents, the mom was exposed prenatally, but also early life. So what are the challenges in studying pediatric cancers and adolescent and young adult cancer as well? As epidemiologists, we've been struggling with the fact that those are rare cancers, about 25 less frequent than adults. So we are really trying to work with a large database, working with cancer registry database, or to form some international collaboration to increase the sample size. I've told you that cancers are heterogeneous, even within the same type of cancer, leukemia, definitely childhood brain tumor. There are many different subtypes, so that also increases our complexity. And these characteristics led to the fact that case control design is still the most efficient way to investigate childhood cancer, but we're faced with retrospective ascertainment of exposure, which brings this complexity, and which brings the fact that biomarkers and biospecimen have not been collected in large scale for those studies, and are still kind of lacking behind. However, we've learned a little bit more recently. And again, looking at childhood cancer or early onset cancer, it is really important to go back in time and look at the fetal origin of some of those cancers. The child that develop cancer at 2 years old is unusual, and that probes the question: what happened prenatally, not just early life years. So multidisciplinary approach has been taken to try to tackle this, question: what causes childhood cancers? And it had taken many different forms from different investigators, whether it's interviewing the parents, whether it's understanding where the family lived before the child was born and after the child was born, and doing some GIS spatial studies. We, in our study in California, went back to the home to sample the dust and to find, other chemicals that could not be investigated with those more traditional methods. And more recently, we've added some component of biomarker studies, whether it was collecting a specimen at birth or collecting a specimen for the mom or the child after she or he was born. And those studies have been very useful to dive a little bit more into the complexity of assessing the exposure, but also assessing the tumor itself. And those are just example of how we've learned how to use those biospecimens. We have investigated the role of maternal smoking during pregnancy and childhood leukemia risk. And that was, in general, very difficult. We were not able to really show a direct link between smoking and childhood leukemia. And the question was that, is the interview not reliable? So we've done some biomarker studies using protein adducts that are known to be, specific to some compounds that are from tobacco smoke. And indeed, we were actually able to correlate some of those protein adducts with the self-report, telling us that maybe self-report was not that bad. And more recently, some groups have validated epigenetic markers of smoking during pregnancy. And we have looked at those in the context of our interview data to, again, being able to correlate our interview data quite well with our biomarkers. So this is an example where, molecular epidemiology can help you refine your work in a large scale. What it has helped us to do also is that we were able to access to tumor tissue, here bone marrow and blood for leukemia, and define those subtype with more accuracy, and understand if different chromosome abnormality or deletion could have different pathway in terms of etiological pathway. And here what we found is that a mom who was reporting smoking was more likely to have a child with certain type of deletion, and that was demonstrated not only using self-report, but using those validated markers. So here we can combine refined exposure assessment with refined tumor genetics to uncover some pathway that we could not find had we just looked at overall leukemia. And over the course of the research that was done in the last 20 years, the discovery of the exposome concept has been quite life-changing for us as researchers, where the earlier model was to go from a targeted search on candidate exposure and chemical to try to really be specific about this relationship. But exposome models has opened the world of investigating the totality of our world that we live in and see how that could impact any outcome, and to go from a targeted search to an untargeted search to generate new hypotheses. Childhood cancer also is a very good model to understand the developmental origin of health and disease theory that is being applied to other conditions, not just cancer. But this is definitely a prime example of how we can look back in what happened in utero to understand the impact in early life. But I would say that this is not to forget that the period of preconception is also very important. And we as investigators of childhood cancer studies have focused on this prenatal period as well, pushing back to the preconception. Finally, as I said, childhood cancer is heterogeneous. So understand the specific subtype that can be linked to a specific causal agent is a very important and can lead to understanding of what the relationship can be at a very, very detailed level. So what have we learned as epidemiologists in the context of childhood leukemia and what causes childhood leukemia using those tools? 25 years ago, factors accounted for less than 10%. And mostly those were genetic syndromes and X-rays. With this wealth of information over the past 20, 30 years has given us from researchers all over the world is that we have identified many, many environmental risk factors that are increasing the risk of childhood leukemia. We have also identified conditions that reduce the risk of childhood leukemia, like breastfeeding, healthy eating during pregnancy, healthy growth. But we still don't know a lot. We still have a lot that we haven't identified and that could be linked to childhood cancers. And so as we were working with those fairly large epidemiologic studies, other groups have faced the difficulty of investigating cancer cluster. Some of them have been quite successful, although over a long period of time, to establish links to contamination to hair tractor TCE compounds in the context of this childhood leukemia cluster in Massachusetts. And some of those chemicals are known to be carcinogenic in adults. And some of those chemicals have been associated with childhood leukemia in some of our studies. So everything fits well. But many pediatric cancer clusters have not been solved. And the link to any suspected causal agent has not been identified. So this is where today I'm really pleased to see that we're bringing to the table a lot of researchers in this field that have looked at childhood cancers and can bring novel ideas in terms of being proactive to monitor spatial and temporal clusters at the smaller resolution, or to incorporate many of those molecular tools that we epidemiologists have used in a combination to biologists and geneticists and many different disciplines that have tackled the problem of understanding what causes childhood leukemia. So today we'll be hearing about genetics, germline, tumor genetics, epigenetics, exposomics, all those tools we have started to use and be successful. And I hope that we're going to be able to bring these two worlds together and not, investigate in silo, but create some bridges to help each other understand those unusual patterns of childhood cancer that can be so difficult to investigate. So with this, I would like to thank the organizer and all the speakers that I will be listening to with great attention.